Today I'm going to talk about Alirocumab and cardiovascular outcomes after acute coronary syndrome. As a definition, in the Odyssey Outcomes trial, we tested the hypothesis that treatment with Alirocumab, a fully human monoclonal antibody to PCSK9, will result in a lower risk of recurrent ischemic cardiovascular events than placebo among patients who had an acute coronary syndrome within the preceding 1 to 12 months and who have levels of atherogenic lipoproteins that exceed specified thresholds despite statin therapy at a high-intensity dose or at the maximum tolerated dose.
The rationale of the Odyssey trial was really that lower levels of LDL cholesterol would reduce important cardiovascular events, potentially including mortality. The design was to test that hypothesis by randomizing patients who had an acute coronary syndrome 1 to 12 months prior to either the PCSK9 inhibitor Alirocumab or to placebo, and then to follow them over hopefully several years. That was the plan. We ended up actually following them for a median of just under 3 years. And the goal was to see if there was an impact on cardiovascular events, including mortality.
As applications in medical English, patients who have had an acute coronary syndrome are at a high risk for recurrent ischemic cardiovascular events. We sought to determine whether Alirocumab, a human monoclonal antibody to proprotein convertase subtilisin gexin type 9 or PCSK9, will improve cardiovascular outcomes after an acute coronary syndrome in patients receiving high-intensity statin therapy.
So we did the Odyssey Outcomes trial to test the hypothesis that patients with recent ACS, not at goal on maximal statin therapy, would derive clinical benefit in terms of outcomes from adding Alirocumab to their secondary prevention therapy. And we did this because despite all the progress we've made in the care of ACS patients, they remain at substantial residual risk. In fact, they are the group of all patients with acute coronary disease, with coronary artery disease, who have the highest risk of subsequent adverse events. So we tested this in a large outcomes trial, enrolling patients not at goal on truly maximal statin therapy following an ACS 1 to 12 months prior to that.
As to the pros and cons mentioned in the after video, the median duration of follow-up was 2.8 years, a total of 334 patients in the Alirocumab group and 392 patients in the placebo group died. The absolute benefit of the Alirocumab with respect to the composite primary endpoint was greater among patients who had a baseline LDL cholesterol level of 100 milligrams or more per deciliter than among patients who had a lower baseline level. The incidence of adverse events was similar in the two groups, with the exception of local injection site reactions.
A variety of published post-hoc analyses. So I think the data is less sparse with Alirocumab than Evolocumab. So I think it would be very difficult to parse out indications or recommendations when you don't really have the full story from both drugs. I think the drugs work in a very similar mechanism. Cost is always a concern. I don't know what we're going to see in the next set of guidelines, but potentially at least including cost in the way we think about and understand additional or incremental medication allotment, it might be a key part of that. And so where cost lays out in the difference between these two drugs may play a role in choice down the road. But certainly as of today, that has not made its way into our current guidelines and thinking.
As to the issue applied in Ecuador, FDA approved the use of Alirocumab for commercial purposes as an option to conventional treatment for acute coronary syndrome, meaning that this drug could come to Ecuador in any moment. As a conclusion, among patients who had a previous acute coronary syndrome who were receiving high-intensity statin therapy, the risk of recurrent ischemic cardiovascular events was lower among those who received Alirocumab than among those who received a placebo. Thank you very much.